By the time I got there, they were intubating her. Her kids were absolutely beside themselves. They were trying to wake her up. And as I was talking with them, they were kind of realizing, like, oh my gosh, our mom is going to die. She's not going to be at my birthday party, and she's not going to be at my graduation. There's so little that I can actually do to make anything about this better. But bearing witness to the grief and the suffering and letting people feel how they feel in that moment can help them feel validated. To say something helpful could be like, I can't even begin to understand how you must be feeling right now. I'm just in awe that you have to deal with this.
Welcome, Regan Marooney, to the Say This, Not That podcast. Regan is a certified hospice and palliative care nurse practitioner at Memorial Sloan Kettering Cancer Center. She attended Boston College School for Nursing and has a graduate degree from Vanderbilt University School for Nursing, where she obtained her master's of nursing and completed the hospice and palliative medicine advanced practice provider fellowship in 2022. I've gotten to know Regan. We're from the same hometown. Our families are friends. And one of the positive outcomes, I would say, of the COVID pandemic for me was getting to spend more time with Regan, because we were living in a place that was relatively close and we were able to connect while socially distanced outdoors.
Definitely.
Outdoors and on Zoom. And, I've always really been personally impressed with Reagan's just approach to life and people. She just has such an open-hearted, genuine sensibility and really sees the world through such a wonderful lens. And I know that we'll get into that today. And the fact that she's chosen to spend her life's work in hospice and palliative care, I think particularly at such a young age, is really telling about how she sees the world. And so I'm excited for us to dig in on that and learn some of the say this, not that practices. I know Reagan's had a lot of different experiences that will be helpful for us to learn from. So welcome, Reagan.
Yes, Kristen, thank you so much. That was such a warm welcome. And I really look up to you in so many ways. You have so many different talents, and you're so great at building community and bringing people together. And I think this podcast platform is phenomenal. I think so often there really isn't a right thing to say, but it really requires us to really think deeply about our intentions when interacting with other people, especially people who are going through hard times. And I'm really looking forward to diving into talking about some of my experiences and hopefully some advice I can I can give, and also advice that I can take myself. I have had so many instances as well where I'm like, wow, I really probably shouldn't have said that. That wasn't helpful. So even for someone whose job is to really dig into difficult communication and sharing bad news, it's really challenging to always come up with the right thing to say. I remember my a summer going into my sophomore year, I had a family friend who lost someone very dear to him from cancer, and she spent her final days at Calvary Hospital in the Bronx. And he had asked me if I had ever considered palliative care or hospice nursing, and asked if I would want a position over the summer working in that hospital. And to me, when I thought about nursing, I didn't think about taking care of patients who needed antibiotics for strep throat, or who came into the ER and broke a foot and needed a fix. I always thought about taking care of people who are dying and approaching the end of their lives. That's always what the nurse role looked like in my mind. And so that again seemed like the right fit for me and like something I should be doing. So that summer, spending time at Calvary Hospital really opened my eyes to the type of care that people receive at the end of their lives, that was so vastly different from anything I had learned about in nursing school. We're always learning to focus on treating illnesses and curing illnesses and helping people to feel better in that way and eradicating disease, but we're not focused on what to do when there's no further cancer-directed therapy for somebody. Then how do we maintain their quality of life and help them and their family find peace and connection and meaning in those final days? And that type of work, also the type of really mundane work of preserving people's dignity, like cleaning them and brushing their teeth and helping them to feel human again when they're stuck in bed and are losing their independence. It just felt like something really sacred to me, and to witness these amazing women who have been doing this, women and men, but a lot of women who have been doing this work for decades, was really humbling to me, and I knew that was a place I wanted to spend my career in. So eventually I graduated from BC and I worked as an inpatient nurse on an oncology hematology floor at Mount Sinai, which was where I very quickly realized how much I love nursing and how I felt like I could have a greater impact on my patients as a nurse practitioner. I oftentimes felt like I was administering chemotherapy and in the rooms with patients who are approaching the end of their lives and their families, and these patients didn't realize how much time they had left or didn't realize how sick they were, and I felt like they had choices that they could make about how they wanted to spend their time, but these things weren't being presented as choices. It was just, "This is what we're doing," and, without really zooming out and looking at the bigger picture of the context of someone's entire life. So I knew that I wanted to become a nurse practitioner so I can have a greater impact on my patients and really be an advocate for them.
That's beautiful. I think it's helpful for people to have the context of your
Yeah.
journey, of your vocation from an early time in your life, to say not only did you know you wanted to have a call to nursing, but then to go down this route into palliative care, which I think is in a lot of cases misunderstood or just not understood if you haven't had direct exposure to it. I think some
Yes.
folks hear the word hospice and they may or may not have known somebody in their life that it was, a few days before the end of their life. And something that was
Mhm.
interesting for me to learn years ago, when my best friend was diagnosed with a rare form of ovarian cancer, was learning about palliative care. There were some palliative care physicians and nurses that came in to consult with her at a certain point after she had tried a number of experimental treatments, and realizing that it's not always just the final day. Like, it is a component of the final days, but that you talked about quality of life can be more than that, and understanding that you can have different conversations. I think, that's just a real practical topic that we may cover for a minute or two here,
Yes.
in the idea of say this, not that, is to kind of introduce what this is so that people know, hey, they can ask for this, and under like what the maybe
Yes.
you can even define for us, like, what does quality of life mean for folks that might not be as familiar with some of this language in the medical context.
Yeah, absolutely. I think it's important to also just distinguish palliative care and hospice care.
Yeah, that'd be great.
Um, so palliative care, to palliate means to alleviate or to make better. So palliative care in a broad sense is symptom management and optimizing quality of life. Palliative care can be provided concurrently with cancer-directed therapy and can also be given outside of the context of cancer. I just have cancer in my brain kind of working at this place, but palliative care can be given to anyone with a chronic or terminal illness, whether it be heart failure or something different than cancer. But in my context, it's used in the cancer world. And palliative care, and like I said, entails symptom management, and can be given across the illness trajectory. So when someone is first diagnosed with a serious metastatic advanced cancer, it is completely appropriate to also consult palliative care so that we can help folks talking about advanced care planning, end of life preferences. And again, those things we don't need to really get into on the first day that somebody's diagnosed with an awful cancer. We're not there to be the grim reaper and scare people, but we're really there to build a relationship with people and to get to know folks and their families and to find out what matters to them, to find out what's most important to them and what quality of life means to them. Because quality of life is really something that's so individualized based on each person, and each family. And then hospice care is kind of falls under the umbrella of palliative care, but hospice is an insurance benefit that's provided when patients have an estimated prognosis of 6 months or less. So that really truly is end of life care. And it can be provided either in the home setting or in the inpatient setting at a hospice facility like Calvary, where I had worked that one summer in college. And we partner with Calvary at MSK as well. and other hospices kind of in the tri-state area. And that kind of care setting really depends on symptom burden and family decision as to where the best setting is for that person. But palliative care is something that can be provided across the illness trajectory. I see patients in the hospital, but I work closely with nurse practitioners and doctors who see patients on an outpatient basis. Maybe the same day a patient's going to get their chemotherapy, we're checking in on that patient to see how's your nausea, how's your insomnia, your anxiety, how can we help with your pain management. We help with a lot of different things, and we wear a lot of different hats. In the hospital, I've had patients say to me, like, after talking to them, they're like, "Oh, and who are you again?" And I'll say, "Oh, I'm a nurse practitioner." From and at MSK, our name is supportive care. So that, not to make things even more complicated, but with supportive care, people are like, "Are you a chaplain? Are you a social worker?" And I'm like, Whatever you need me to be, I can be." But that's the other great thing about palliative care is we do have a full interdisciplinary team. So we do work closely with chaplains and social workers and pharmacists and really tailor the care. But at the forefront of our job is like advocating for patients, trying to help streamline communication between teams, and advocating for patients' wishes and helping patients and families navigate making difficult decisions, which so many people have to do on a daily basis around here.
So I wonder if you can talk a little bit more. You mentioned earlier the comments that you would hear when people understand what your job is, and they make an assumption and say, "Oh, that must be so sad. You're dealing with people who are dying or close to death." And you had that beautiful reframe of, and yes, also I get to see these tremendous feats of love and bravery and the best of humanity. So I wonder if you can tell us a little bit about um yeah, what are some of the things, that, like, in that context that you found are helpful to say, or how do you reframe when people make sort of a assumption that's not accurate and say something that how do you shift it the other way, right? Like,
Yes, I think exactly what you did, which is a lot of "and" statements, of being like, it could be 2 things at once. It can be very hard and sad, and it can also open my eyes to see in a new way. And your job must be hard and sad for other reasons too. Like, maybe you don't feel fulfilled in your role, or maybe you feel like you're bored, or whatever it may be, but everyone has a job, and that's how the whole world goes round. But just yeah, I think acknowledging the dichotomy of two beliefs and two feelings can exist at once. And even with talking with people who are grieving or going through hard times, I think not trying to put your interpretation of their experience onto them, but just allowing them to feel the way that they feel without feeling like you need to justify something about their experience.
could we unpack that just a little bit more?
Yeah.
Because I will note that another guest, who has some experience in this field as well, said something similar about how it's really important not to make meaning of somebody else's experience, that, like, they can make their own meaning of their experiences. And so
Yes.
as you're noting that, what do you do or say in that space to allow them to make that meaning?
Yeah, I mean, that's a great question. And it's a great question. In terms of like meaning, well, I'm thinking the only thing I can think about right now, honestly, is a patient that I just saw like 2 hours ago who came into our urgent care. She's 44 years old. She has 2 kids who are teenagers and a husband. And something acute must have happened because she has advanced metastatic rectal cancer and with disease in her lungs. And she came into the hospital and she was having trouble breathing this morning. She was having chest pain. And I was consulted to help with symptom management because she was having trouble breathing. But by the time I got there, they were intubating her and getting her ready to go to the ICU. So, when I arrived, her kids were at her bedside. Her husband was, in the hallway on the phone with her parents, and her kids were absolutely beside themselves. They were trying to wake her up. They were trying to shake her. So I actually physically took the kids outside the room and I pulled them away and we found the husband and I asked him if he could get off the phone so we could talk about what's going on. And as I was talking with them, they were kind of realizing like, "Oh my gosh, our mom is going to die," which is something that I think they had known since she had been diagnosed with cancer 5 or 6 years ago, but not something that you ever wanna bring yourself to think about in real time, and certainly this is not the traditional end of life process. It sounds like something acute happened and the her disease trajectory, everything kinda changed today. So they were really not prepared for this, and as they're talking about, "Oh my gosh, our mom's not gonna die. She's not gonna be at my birthday party, and she's not gonna be at my graduation." And they're experiencing this grief in real time. And I'm just sitting there listening to them naming the things that they're experiencing, and we're in the hallway, so it's a very public place, and there's people who see them crying, who are coming over with boxes of tissues to try to be helpful. And by the way, this is kind of different from the meaning making, but I will bring it I will bring it back
This is an important
full
story.
circle. And, like, they were drying their tears, and they'd be like, "I'm good on the tissues." And then someone else would come over because, like, seeing somebody grieving in that way, you want to do something and be able to offer something to make this less terrible. But in that moment, there was nothing that anyone can do or bring. And I actually said I felt like I didn't know what my intervention was there because I was initially consulted for symptom management, but now she's sedated and being intubated, and I felt like I was a bouncer for the family because I was actually, like, shooing people away. I was like, "Let's just let them they don't need another box of tissues. The box of tissues is not gonna fix the fact that their mom is going to die." So, I felt like that was kind of my role, but in that way, in terms of, like, the meaning making, I think it it reflects on the way that when people witness other people grieving or going through something really awful, it is uncomfortable to watch. And not only is it uncomfortable, most people have empathy and compassion and want to be able to do something that's gonna make that person feel better. And I think the people handing the tissues were the people who wanted to hand the tissues and for them to be like, "Oh, thank you so much. Those tissues, I feel so much better now." But there's nothing that we can hand them or do or say that's going to make anything about the situation better. It was just such a nightmare. So in that moment, I felt like I was a bouncer and doing the opposite of the meaning making, but just letting them feel how they felt, and just grieve in that raw moment,
Being there. So it sounds like being there and not
being
even
there.
saying things or maybe even mirroring back or repeating what they may have said while you're
Yes.
there.
Yes, exactly. I think presence can do so much. And also after doing this job for a couple of years, I've come to realize I remember like when I first started, I was always like, okay, I better think really hard about what I'm going to say to patients who are and families who are going through these really awful times because I want to act as an instrument of love and I want to make things better. But at the root of every of these awful situations, there's so little it's actually not about me at all. There's so little that I can actually do to make anything about this better, but bearing witness to the grief and the suffering and letting people feel how they feel in that moment can help them feel validated and, more at peace. I'd like to think.
I'm sure that's the case. I'm sure that's the case.
I hope.
Reagan, I'm curious because in your day-to-day job, you are bearing witness to so much suffering and grief, as well as the acts of love and service that you described as well. But I'm wondering how how do you get through it? You know, is there something who and how bears witness to you um in your own world to continue on to have that support to continue to do the work that you do?
That's a great question. I think unfortunately my husband Mac really bears the brunt of my hard days because and I also like to think that I have healthy boundaries between work and home. The boundaries were certainly blurred for a long time when I was first starting in this job. I didn't know how can you bear witness to all this sadness, and I live a couple blocks away from the hospital, so I would be home at night thinking about my patients in their beds in pain so close to me, and for some reason, I'm in my apartment healthy without pain, and it just reconciling those two worlds coexisting was really, really hard for me. And I harbored a lot of anger at like God and the world for just allowing those things to exist, and guilt in feeling so healthy and free and alive and feeling like I could breathe easily. So that's really challenging. And I think developing healthy boundaries comes from building a great community of my husband. I now have a 1-year-old son who I just look at him and I wonder how bad things could ever happen when he smiles and he sings and he laughs. He gives me so much love and so much peace. And so it's hard to think, how can I be angry and miserable when I'm with these people who love me so much? And I can only hope that everyone doing this kind of work has a community of friends and family who build them up and allow them the space to talk about hard things. But it's also hard because I don't want to make everyone sad, at dinner. How was your day? Oh, you actually probably don't want to know how my day was. I'm not going to bring it up because I don't want to be the Grim Reaper with my pitchfork talking about sad things happening at the hospital. So I think it's balancing it all. And something that's very prevalent on my team as well is humor. We find we find the ability to laugh at things and to just sit in awe of what we're asked to do sometimes. And we have a great community and support system between all our team as
Do you
well,
have a
which is
good
so helpful.
story that you're comfortable sharing that comes to mind of something that you all might have been laughing about, whether it was recent or a while back?
Yeah, I mean, I'm just thinking we have a message from a doctor printed out and pasted in our cubicle workspace, and he's talking about home hospice, and he called it ho-ho, which we were like, "Oh god." We're like, "Well, please don't abbreviate it and call it that." It's like home hospice, but some of the abbreviations and the way that people talk about death so cavalierly is like really it sometimes we just need to laugh and acknowledge that we are have a crazy job. We're asked to do some crazy things sometimes.
I would imagine. Um, are there things and phrases um, that you've sort of I want to say accumulated, but are there phrases that you say over the years as you begin these encounters with people, or that you would recommend? If we think about the framework of say this, not that, is there
Mhm.
something when um, a family member gets a diagnosis or somebody else, gets a diagnosis that you would recommend a caring individual to say to be supportive when they're first encountering them rather than to unintentionally, right? The folks that you described handing the tissues, they wanted to be helpful, but
Yes.
so,
Yes.
part of this dialogue is to unearth, oh, do you have some recommendations of really simple things that you all probably have an arsenal of really simple things that you say that, to your point, are not necessarily going to make it better, but are going to indicate that you're willing to bear witness.
Yes. I think, and I'm not sure if you've had other healthcare folks on the podcast who have talked about this before, but something that we're taught and that we use oftentimes not realizing that we're utilizing this framework is the nurse mnemonic, which is like a communication framework for expressing empathy and responding to like challenging statements, essentially. And so the nurse mnemonic, the N stands for naming the emotion, basically. And I've had that go well for me, and I've also had that go south because you can be very wrong, but it's a very quick way to gather more information about how somebody's feeling. I could say something like, "Wow, you seem so upset right now." And the person might say, "I'm actually not upset. I'm pissed off, and here's why." And they might give you more information or, I'm actually just frustrated and here's why. So kind of like naming the emotion, that's kind of the elephant in the room when you're talking with somebody and feeling their energy and they seem to be feeling one way, it's important to try to name that feeling. And then the U stands for understand. And I think this brings up a good point too, because something you actually don't want to use understand statements when talking to somebody because no, I can never understand what a patient or a family member is going through. Even if I've experienced a very similar situation in my family or whatever it may be, I I'm not that person and I'm not going through their individual experience. So saying something that's not helpful would be like, I understand what you're going through right now. And I've seen other people say that accidentally, trying to bear witness to that feeling and saying that they understand, and patients and family members being like, "You actually don't understand. Has your son ever died? Or has your child ever been this sick?" And then it creates this whole dynamic. But to say something helpful could be like, "I can't even begin to understand how you must be feeling right now. I'm just in awe that you have to deal with this." And just saying like, "I can't even begin to understand," can at least acknowledge how difficult that situation is. And then the next piece is the R is respect, which kind of ties with the understand piece is just being in awe of what somebody has to carry and how they're carrying it and acknowledging those things. So, like when I talk with patients' families, I try to understand, I try to spend time with them and understand more about their life outside of the hospital and in the context of their family dynamic, what's been going on. And I usually learn a lot of information, like besides my dad being in the hospital, I'm a single mom and I have to take care of kids and I have to go to work. And also my brother is mentally ill and whatever it may be. So I could say something like, "Wow, I don't know how you're dealing with all of this, but you're the fact that you have to take care of your dad on top," kind of reflecting what they're going through. Take care of your dad on top of taking care of your children, worrying about paying the bills and the mental health of your brother. That is something that nobody should ever have to deal with, and you are dealing with it right now so beautifully. I can't imagine having to do that for my family, truly. And typically, people will feel so seen by you. All you're doing is just echoing the things that they're complaining about or the things that they're sharing with you that are hard for them and helping them feel validated by using that respect piece. And then the S is just support and saying something that you mean. Usually telling patients or family members or friends, like, "I'm here for you and I'm going to be here for you." And I usually use this statement when I am consulted for a patient who is in pain crisis, who I go to see them and they are screaming in pain. And I will tell them, "I am not going to leave you until you're feeling better. I'm not going anywhere. I'm not going to leave you until you're out of this pain." And I also try to remind patients, and sometimes I have to lie to myself because I don't know. I don't know that this is the worst, but I try to tell patients who are in pain crisis, "You're in the worst of it right now. This is the worst it's going to be, and you are getting through it. It's only gonna get better. Right now, I'm here, and we're giving you the pain medication, and it's only going to get better. This is the worst, and you're breathing through it, and you're in it." So I think being there with that person and not being like, "Okay, I'm gonna order some meds, and I'm gonna go leave," that doesn't really convey the same amount of support that actually saying, "I'm gonna stay here until you're feeling better," really does, because that's a promise to the patient. And then the E is just explore. So, like, just learning more about kind of self-explanatory, learning more about what they've said and trying to gather more information and really giving people the time. So, in the context of your question, like, if someone is newly diagnosed with the cancer and you're a friend who's learning this information, I think I would just say, "Oh my gosh, wow. I am so sorry. I can't even imagine what you must be going through right now, and I love you so much, and I'm here to support you, and you don't have to worry about, you know, telling me this now and then down the road I'm always going to be here for you," kind of thing. Because I think also it's hard when you say, "I wanna support you," and then you're leaving that person with the task of having to find ways to help you to feel like you are helping. So I think
It's
just
a
being
lot.
like,
Yeah.
"Yeah, I'm here to support you and I'm gonna keep checking in on you. And, I just, I love you and I'm amazed by what you have to go through right now." Um, and I think sometimes acknowledging too, like, that this isn't fair. And because people will say, like those kids today were saying to me, "How is our mom dying? This is not fair." And what am I supposed to say that's going to make that better? I just said it's not fair. "Oh my gosh, it's not fair at all. This is terrible. This is a nightmare." And I don't know what to say. Like, and I think that that's validating too, just to know that this really isn't fair. And, yeah, I think sometimes patients and families could also rack their brains for the why. Like, why is this happening? And I think that puts people down a really bad path, especially patients. I had a patient a couple weeks ago who said to me, "Oh, like I if I only exercise more, maybe I wouldn't have gotten this cancer and maybe I wouldn't have to go home with hospice right now." And I just thought, "Oh, I and I said it's so easy to go back and look into the past and to think about what you could have done differently, but I want you to know is nothing that you did is causing you to be in this position. Like, you take the blame off of yourself because looking back is just you're gonna go down this path where, you know, it's not gonna be helpful. It's not gonna be helpful, but it's so hard."
That's so helpful. The mnemonic itself is incredibly helpful, and I think especially that I'm here. I'm going to support you, and I'm going to keep checking in on you. I think
Mhm.
that's a really useful phrase and way to frame things that lots of people can use. And I think in terms of say this, and then especially when we think about don't say that is the way you unpacked I understand how you're feeling.
Mhm.
Right? Don't say that. You don't understand. I think you
Right.
articulated that so beautifully that there's a way to indicate and appreciate that you can't understand because even if you have lost a spouse, lost a child, lost a friend, like even if you had something that appears similar, you've not lived that person's exact experience. And so acknowledging that in some way, shape, or form and that it's not fair,
Exactly.
I think is really helpful. Yeah, that's great.
Exactly. I think I've come to learn, through this work that there isn't always the right thing to say, but there's so much in your presence and in trying to make a terrible situation a little less terrible, and just accompanying someone through that situation and bearing witness to the grief. I think it does more sometimes actions do more than words, and it makes people feel a certain way. And I try to meet people where they are when I meet them because everybody is different and everybody experiences things differently. We were talking today during our rounds that some patients, while they're in pain, they're not suffering. Like some patients will feel significant pain, but they're emotionally, spiritually, psychologically at peace with what is happening, that they're not suffering the way other patients are. And it's really interesting. Everybody needs something different from you. So you kind of have to morph into what that person needs in that day. Like, when I enter a patient's room, I try to make myself physically and and metaphorically as small as I can be to figure out what they need from me and to try to provide that in that moment.
Would you So I'm interested in this for two reasons. One, because I have these really fond memories of an oncology nurse at Memorial Sloan Kettering who came into my friend's room and who um, shifted the energy, just had this sort of positive sensibility and shifted the
Mhm.
energy in the room in a positive way every time. And sometimes it wasn't about, I mean, she happened to have a really sarcastic, like witty sense of humor
That
that,
helps.
to your point about humor,
Yeah.
helped a lot, I think, but also was realistic about things and wasn't Pollyannish about things and could
Yeah.
understand how to work through. And so I remember thinking, oh, wow, you can change the energy of the room by how you enter it sometimes
Absolutely.
and how to think about that. And so I wonder, this idea of as you enter, you're conscious of how do I be most helpful to the other person. I heard that as that could be very useful guidance for any of us out in the real world,
Yes.
getting out of our own way. If you genuinely want to be supportive, take a moment to think about, okay, how do you take in who this person is and how they are in that moment, and put yourself aside to be able to be the most useful.
Yes, absolutely. And, especially in the world of the hospital and in medicine, we are all overworked. We're seeing so many patients every day. And so the best thing for me and for providers is to go into a room with an agenda of things that you want to talk about and checkpoints that you need to check off and things that you're going to document in your note. And so you want to go in and get out and get the information that you need from the patient and share the information that you need to share. So it's easy to not do that, especially when time isn't on our side, because it really requires time and sitting in discomfort sometimes. And when I said physically making myself small, when I walk into patients' rooms, I don't like the way it feels to to stand next to somebody who's laying in bed and to tower over them. It just makes me uncomfortable. I imagine being the person in bed. Someone's like talking over me and is asking, "How is your pain? And how is your night? And what do you want to do about this?" And it just doesn't feel good. And I don't like being the person who's standing over somebody. So I usually will either kneel next to them or like crouch down next to them, which quickly got me in trouble when I was pregnant. I would like lose feeling in my legs and I was like, I can't keep doing this. Or sometimes patients will be like, "Do you want to sit at the edge of my bed?" And I'll be like, "Sure," when they see me kneeling. So sometimes I'll sit at the edge of their bed, which not is not for everybody. Or if there's a chair, I'll pull it over and sit on a chair like a visitor would. But I don't like the feeling of like talking down to somebody. It just doesn't make me feel good. So I think also like even in interpersonal conversation, thinking about how that person is perceiving your presence and your energy is so important, and just letting go of the way that you thought the conversation was going to go, or letting go of the things that you wanted to say, and just trying to absorb someone else's energy and to try to figure out what they need from you in that moment. And especially in my job, we do a lot of pain management, symptom management. But like I said, we wear many hats. So usually just go into somebody's room now and just say, "Hi, my name's Regan. I'm a supportive care nurse practitioner. We're helping with pain and symptoms. We help with lots of things. I help make difficult decisions. But I want to get to know you better as a person. But for right now, how was your night?" And usually that will give me some insight, like, "Oh, my night was terrible because I was in so much pain," or "Actually slept too well." But whatever they want to share with me, I kind of leave the door open for them to share what they want to share instead of focusing on one thing. Um, but yeah.
That's so That's so interesting and important, and I think really useful that you think about the physical presence. And
Yes.
it's really important to pay attention to. And I'm sure it makes a huge difference in the context of that hospital setting, but really in our daily lives as well. And I think that that's one that I hadn't really thought much about that I'm grateful for you bringing up and calling more attention to. Reagan, you talked about accompanying people through this and how difficult this can be and how much discomfort there is
Mhm.
in many of these encounters and yet you do this every day. I'm wondering if you can maybe talk a little bit about what has helped you over the years um be more okay in the process of accompanying in the discomfort as you go through it, because it doesn't get more comfortable for you probably, right? Like it's still
Yes.
uncomfortable, but sort of what has helped? Is it just doing it? What has helped as we encourage other folks to move into that place of discomfort in order to be the support and in order to bear witness?
Yeah, I think that's a great question. And I think it comes with time and experience and learning to just let go of the way that I feel. Like this situation is not about me at all. And it's going to bring up feelings for me. Of course, watching something terrible, watching people crying in pain, watching people suffering at the end of their lives. That's going to make me feel terrible, and especially because my job is to help with pain and symptom management. So if someone's really symptomatic and is really struggling to breathe at the end of their lives, I'm gonna feel personally a little bit responsible for not, being aggressive enough in my symptom management or not having the right opioids to give them or not having the right tools to make them feel comfortable. So it's easy to kind of absorb those emotions, but I think I've come to learn, like, it's just not I can't be thinking about how my response is not important right now. All that matters is the people in front of me and trying to really let go of that. I think something I also struggled with initially when starting this job was just internalizing the pain of and suffering of other people, like, kind of putting myself in their shoes, which I think is important to provide good care. You have to care for people as if that was your mom or your dad or your brother because you would want other people providing that care to your loved one. So you have to go there a little bit, but also not getting too bogged down by how sad that can feel to imagine a traumatic experience for yourself. And I think learning to kind of maintain a boundary of caring really deeply, like a patient is your loved one, but also at the end of the day, this is my job and I'm going to go home to my family and I don't have cancer and I'm not in this right now. And really trying to remind myself like this is my job. It is a vocation, it is a calling, and it is something that I feel grateful to be able to do. But at the end of the day, I'm getting paid. This is my job and it's not about me. And so I just need to take a step back.
That's great. That's great. So I wonder, I like to ask our guests if you could wave a magic wand and eliminate something, that people have said that
Oh,
would not be said anymore. What would you, is there a phrase that you would like to eliminate people saying?
yes. For me, it's at least. I
Ah,
hate when people say that. "Oh, at least you had, at least you got 4 extra years with this cancer that you were supposed to die years ago, and you got this extra time with your family," or, "At least you get to go home and die at home." Not everybody gets to do that, or whatever. Whatever it may be, at least tries to just, like, put a silver lining on something terrible. And again, I think it's more about the person saying it who's, like, trying to come up with something to say that's gonna put a positive spin and make that person feel differently about their grief, and it's never helpful. I mean, maybe sometimes it is, but in the way that I've seen it, that's just not helpful. Like, people are allowed to feel how they feel and grieve how they grieve, and if there's no silver lining right now, that's fine. There doesn't need to be one. It can just be awful. And just because you're uncomfortable doesn't mean you should say something stupid like, "At least."
And I think what I hear in your reference to they're trying to find something positive to say is that ironically, the more positive outcome would come from them applying the nursing mnemonic that you said, which
Yes.
is just acknowledging that it's
Yes.
not fair, it's not right that in order for you to get to something that will feel more positive in the long run, is not to search for the positive words, is not to frame it in that way. So
Exactly.
that's a great learning. Um,
Exactly. And it's something that you naturally wanna do. You wanna help people feel better because, like, at the I know that, there's not everybody is good in the world, but most of us are good. Most of us have compassion and love and care about other people, and so you want to when you're in the face of suffering and sadness and distress, you want to offer something to make that person feel better, and so you say something like that because you mean so well and you want them to feel better, but at the end of the day, like, there's not something that you're gonna say that's gonna tie up their sadness with a bow and send them out the door. That's not how it's gonna go.
yeah. This has been so incredibly helpful, and I've learned so much through this conversation. I want to offer the opportunity. Is there anything else that we haven't covered that you would like to contribute in the context of say this, not that?
A great question. I mean, I think I'll just say, like, I don't always have the right thing to say. And I want to acknowledge that I've said the wrong thing plenty of times, and I've realized, like, as the words were coming out, like, "Oh
Do you
gosh,
have a good
why."
story? Do you have a good story of
Yes,
one of them?
I do because I'm at work today, so I feel like I'm getting the opportunity to practice to say this is not that's all the time. And I had a patient who was in terrible pain. I got off the elevator and I heard a man screaming and I thought, "Oh god, this is my patient." So I ran in there, he was in terrible pain. I told him, "We're ordering pain medication." I got the nurse, talked to the pharmacist, "Please make the pain meds very quickly. His patient is in crisis and we're giving him pain medication." And I'm standing next to him, and all the while his wife and his wife's mom are in the hallway outside beside themselves, crying beside themselves, hearing him crying and screaming in such pain. This is nothing they've ever witnessed before, and it's distressing, of course. So I'm, like, with him. Eventually, after, like, a half hour, we get him comfortable. He's drifting off to sleep. I go out to check in on the patient's wife and her mom, and the first thing I say is, "Are you okay?" Which, as soon as it came out, I was like, "Oh, they're not okay." And that's exactly what the wife's mom looked at me and she goes, "Do we look okay?" I was like, "No, you don't look okay. You're totally right. That was such a stupid thing to say." Like, I owned it. I was like, "I Of course you guys aren't okay. This is a horrible situation. I can't imagine watching your husband and your son-in-law in this much pain. This must be just awful. Like, I'm so sorry. Of course you're not okay, and that's totally fine." And then I kind of reviewed what I did to help get him more comfortable and our plan moving forward to keep him out of that kind of pain. and to consult some other teams to help manage what the issue he was specifically facing. But um, I just want to say that I don't always have the right thing to say. And I just try to be self-aware enough to acknowledge if I didn't say the right thing and to kind of either laugh about it or just to own up and say, "You're right. That was not I shouldn't have said that." Or just to apologize or just acknowledge that we're all human and we're all trying our best, and you might say some things that are great and you might say some things that are not great. But at the end of the day, as long as you genuinely care, you're acknowledging people's feelings and you're bearing witness to their grief and you're not running away from it, they're going to feel a little bit more at peace.
That's so well said.
Thanks, Kristen.
Thank you.